the live stream right now. Just give us a 10-second. Thank you.
Certainly. Well, good morning and welcome. My name is Joe Cressy and I'm the chair of the Board of Health. Our board secretary has confirmed that we have quorum, so I'll call meeting 25 of the Board of Health to order. Welcome to everybody, members of staff, members of the board, and members of the public. In particular, I'd like to extend a special welcome, first of all, to two new members of our board. That is I almost mentioned myself. That is Councillor Bradford and Councillor Ainsley. Because we're remote and I have different screens, are they here with us today? Have they signed in? Flipping through, I don't see them yet, though I know they will be joining. So this is, as board members are aware and members of the public, Councillors Lai and McKelvey, former members of our board, have moved on, and Councillors Bradford and Ainsley have joined us. So a particular welcome to them. And as well, I would like to introduce and welcome formally our Deputy Medical Officer of Health, our new Deputy Medical Officer of Health, Dr. Nakashi Lamptey, who we approved at our last meeting and is here formally with us today. Dr. Lamptey, would you like to say a quick hello and introduce yourself?
Hello, good morning. I'm so delighted to be here, to be working with such a dedicated team. It's good to be home. And I'm so excited to help support Dr. Davila and the entire team at Public Health. I've just been, it's been a bewildering week and so impressive, the dedication of the whole team.
Well, thank you, Dr. Lamptey. For those who don't know Dr. Lamptey, we are privileged, fortunate, and delighted that she is our new Deputy Medical Officer of Health. This is officially day 7. She began last Monday. Quite the week to start. Dr. Lamptey, welcome. It is our luck that you are here with us, helping to steer this ship. Today's meeting is being held by video conference. City staff are also connecting to the meeting by video conference. As City Hall remains closed, the public will continue to participate electronically and can watch the meeting streamed live on YouTube at youtube.com/Toronto City Council Live. I will ask everyone for their patience with any delays and technical issues. That includes I am chairing remotely myself. I am not in the committee room. And so as we work through speaking lists and questioner lists, I can't see all members of the board on one screen. So I might be flipping through or asking you to unmute and indicate an interest in speaking. So to everybody, we're thankful patience with our delays. We currently have 5 registered public speakers. The clerk staff have connected all speakers to the meeting by audio. The list of speakers can be viewed online by visiting the Board of Health's page at toronto.ca/council and clicking the speakers box. The board secretary has also emailed the speakers list to directors. Although we are meeting in different locations and meeting remotely today, the Board of Health would like to acknowledge the land we are meeting on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. Let me begin by asking if there are any declarations of interest under the Municipal Conflict of Interest Act. If you have an interest, please raise your hand, unmute your mic, and indicate the nature of your interest. Dr. Mulligan, yes. Director Mulligan, we can't seem, you're unmuted, but we can't hear you. We still can't hear you, I'm afraid.
Okay, how about now? No? Okay.
There we are. Director Mulligan, we got you. Please go ahead.
Hi, I don't have the number in front of me. I have a declaration of interest on the item related to the Ontario Seniors Dental Program.
Item HL 25.6, Service Agreement for the Ontario Seniors Dental Care Program.
Yes, right. Thank you.
Thank you. When we come time to that item, we'll ask you to turn off your video when we vote on it. Are there any other declarations of interest? I'd ask if members could unmute their mic and indicate so. Okay, hearing none. Next, we need a motion to confirm the minutes from our last board meeting on December the 14th, 2020. Moved by Councillor Perks. All those in favor by a show of hands. Opposed, if any. That carries. All right. The first item, before we do the agenda run through, the first item on the agenda, which we must deal with first, is item HL 25.1, election of a chair for 2021 Board of Health. As we do annually, I will ask the board secretary to conduct the election of the chair. So I will step aside from the chair and turn this over to our board secretary. Julie, over to you.
Directors, are there any nominations for Chair of the Board of Health? Directors may nominate candidates, including themselves, and nominations do not require seconding.
Yes, thank you very much, Julie. It's Councillor Wong Tam. I'd like to nominate Councillor Cressy for the position of the Chair of the Board of Health. He's done an exceptional job. I see no reason for us to shift leadership.
Thank you, Director Wong Tam. So Director Wong Tam has nominated Director Cressy. I am calling for nominations a second time. Are there any further nominations for Chair? I'm calling for nominations a third and final time. Are there any further nominations for Chair? So hearing no further nominations, I declare that the nominations are now closed. As Director Cressy is the only nominee, I declare him the Chair of the Board of Health for a term of office starting January 18th, 2021 and ending December 31st, 2021, and until a successor is appointed. I will now ask Director Cressy to assume the chair in order to conduct the election for Vice Chair and to preside over the rest of the meeting. Thank you, Directors.
Thank you to our recording secretary, and with my deepest and most humble thanks to Councillor Wong Tam and each and every one of you. We now turn to item HL 25.2. We will deal with this item first before we do a run through on the items. This is item HL 25.2, election of a vice chair for 2021 Board of Health. I will call for nominations for vice chair, and I will begin by nominating Councillor Wong Tam to carry forward as our vice chair. Let me also call, are there any other nominations for vice chair? If you would like to indicate a further nomination, if you could unmute your mic. I'm calling nominations a second time. Are there further nominations for vice chair? And a third and final time, are there any nominations for vice chair? Hearing no further nominations, I will declare that nominations are closed. I will ask Councillor Wong Tam, do you accept the nomination? I would note nobody asked if I would accept my nomination. Councillor Wong Tam, do you accept the nomination as vice chair?
Yes, thank you, with honor. And no one asked if you accept your nomination, Councillor. Director Cressy, is because no one wants you to be stepping out of that role.
Well, thank you for that. So congratulations to Councillor Wong Tam, our fearless vice chair. Thank you. I'd like to note, I mentioned them earlier, and I see they've joined us, Councillor Bradford and Councillor Ainsley, two of Toronto's finest from City Council, have joined us formally here at the board. Welcome. And Councillor Bradford, by your next meeting this time, by our next meeting, you will be a new father. He is expecting any day now, him and his wife. So congratulations to that always. All right, we're now going to do the agenda run through. We have, I'll proceed through item HL 25.3, response to COVID-19, January 2021 update. We have speakers and a presentation on that item. A presentation, I should note, for members from Dr. Davila, our Medical Officer of Health, Chief Peg, who is overseeing our immunization task force, as well as Anania Grant from Social Development and Finance and Administration on the Equity Action Plan. So that item is held down. Item HL 25.4, 2021 Board of Health Committees and Appointments. Would anybody like to hold down this item? I do have a motion I can move on it, but would anybody like to hold down the item? And if I could just note, because I can't see everybody on my individual screen, I might ask when it's time, if you could unmute your mic, because I can't always see your people shaking their heads. So I don't hear anybody wishing to hold it down. So with the indulgence of the clerk, I will put forward a motion here on this item. And thank you. I know I have caucused many members of the board in advance on this. This is to appoint the following Board of Health directors to the Board of Health Budget Committee for an additional term. Myself, Trustee Donaldson, Councillor Layton, Trustee LaPretti, and Councillor Perks. Second is to appoint the following Board of Health directors to the Board of Health Performance Appraisal of the Medical Officer of Health Committee for a term. That is reappointing the following: myself, Director Mulligan, and Councillor Wong Tam. And finally, I used the term fearless earlier in regards to Councillor Wong Tam. This applies here too, to reappoint Director Mulligan as our fearless director at the Association of Local Public Health Agencies. So it is my privilege or pleasure to move that. By way of a show of hands, all those in favor? Opposed, if any? That carries. Thank you. Our next item, as we do the run through, is HL 25.5 Student Nutrition Program Update and Resource Needs during COVID-19. This is the follow-up to our work at last month's meeting. Is there anybody who wishes to hold this item down? Okay, seeing none, it's an information item. I do have an amendment that I will move as we dispense with this item. And so I'll, to our recording secretary, with your indulgence, I'll move the amendment. And to be clear, because this is for City Council and the Board of Health to request the province of Ontario to provide the adequate funding to our student nutrition program partners to fully stabilize the program for remote learners during the school period of January to June, when many are learning from home and in need of food at home. Further, for Council and the Board of Health to request the MOH to report in March on the status of additional emergency funding for this program from the province. So we will get an update on the status of that funding and adjust course at that time as necessary. And third, that we forward this report to our partners at the TDSB, the TCDSB, and the Angel Foundation and the Toronto Foundation for Success, as well as the province. So with that, I will move this motion and note again our thanks to our two trustee directors, LaPretti and Donaldson, for their strong work on ensuring student nutrition is available to those who are learning remotely or forced to be at home due to closures. So with that, I'll move that. All those in favor? Opposed, if any? Okay, that carries. And then the final item is item HL 25.6, Service Agreement for the Ontario Seniors Dental Care Program. This is the item for which Director Mulligan did indicate an interest. Let me first see if there's anybody who wishes to hold this item down. Okay, seeing none, what I'll ask, we will take a vote on this item. I see Director Mulligan has left the meeting formally. Her camera is off. So we can take a vote by hand on this. All those in favor? Opposed, if any? That carries. So this brings us back. Thank you, board members. And Director Mulligan is welcome to rejoin the meeting. We will now return to the main item on our agenda, which is item HL 25.3, Response to COVID-19, January 2021 update. We do have 5 registered speakers on this item, but as is our practice, we're going to hear, there is a detailed presentation to come. We're going to receive the presentation, then hear from public speakers before taking it into committee for questions. Providing the presentation, this is a big one. We have Dr. Davila, Chief Peg. You'll recall, members, at our last meeting, we requested a presentation from the City of Toronto's Immunization Task Force, and Chief Peg has joined us here today for that. And we will also have Anania Grant from Social Development and Finance Administration, who's providing an update as part of our work related to the Equity Action Plan and the equity focus through the immunization campaign. So with that, I will hold my thanks to you and your team's hard work till later in my remarks. But Dr. Davila, we turn it over to you. And before you speak, we thank you and your team for the work you're doing. Dr. Davila, over to you.
Thank you, Mr. Chair, and good morning all. And I suppose while it may still be allowed, Happy New Year to all the members of the board. Have not had a chance to see you since the turn of the calendar into the new year. We are going to see on the screen here a presentation that will be delivered in the first part by me, followed by Chief Peg, and then Anania Grant from our colleagues at Social Development, Finance and Administration. Before I begin in earnest, though, if I may, Congratulations to you, Councillors Cressy and Wong Tam, on your re-election to Chair and Vice Chair for the board. We look forward to working with you. Welcome, Councillors Ainsley and Bradford. We too look forward to working with you. And finally, Mr. Chair, if you'll indulge me for a moment, I would like to also welcome Dr. Nakashi Lamptey personally in the role as Deputy Medical Officer of Health. As you noted in your opening remarks, she has been with us for about a week now. And even in those few days, I can assure all the members of the board and the public writ large that she is already demonstrating the incredible skill and value that she brings to the already very strong and very passionate and dedicated TPH team. And we look forward to seeing where we can take public health in Toronto now that we have her on board in this new capacity. So with that, let's start with the presentation in earnest. As you've heard, it will be delivered by three of us. The first part is delivered by me, and it will largely focus on much of the data that we have seen and our COVID-19 experience to date. So let's turn to the next slide, where we have an overall update in respect of the numbers and the perspective on COVID-19, the summary of cases in Toronto. As you'll see on this slide, as of yesterday, January 17th, unfortunately, we've had a total of 77,327 cases of COVID-19 in the city. That is the result of an additional 892 new cases, which we are reporting today. As well today, just to give you a little bit more context, as we have these data, we have 25 new hospitalizations being reported today. That does take us to 491 in hospital. There were 5 new admissions to ICU. We have 113 now currently sitting in ICU at this point in time. So there's no question. COVID-19 activity in our community is very, very high. This is something that continues to be very much the subject of the primary occupation of that which Toronto Public Health is doing, the entire team at Toronto Public Health. We will continue to provide you with these updates in respect of the number of cases throughout the city and to give you these kinds of breakdowns, including the things that we see on our website, so that people are informed about that which is happening. As vaccine becomes more prominent in our setting over time, future versions of the data presentations that we'll put forward both to the board and the public will include the number of those vaccinated as we start to move towards that focus on protecting the population through the administration of vaccine. So turning to the next slide, to give you a little bit more by way of specific data on what case increases look like in the city of Toronto, you'll see here a little cut from our monitoring dashboard, and these are data as of Friday, January 15th. Our monitoring dashboard is updated on Mondays, Wednesdays, and Fridays. And I regret to inform you that the pattern suggests that the numbers that we will be reporting today, as that dashboard gets updated later today, will be even higher, unfortunately, than that which you're seeing here, which are, of course, Friday's data. You can see that cases are continuing to climb. Our 7-day moving average is 852 as of Friday, January the 15th. And we have overall seen a sharp increase in daily COVID-19 counts since late December following the holidays. You'll note here as well that the 7-day moving average for new hospitalizations is 37. That's in that middle section of the graph. And we also know that there are currently 106 active outbreaks. And this is actually near the high watermark that we saw in the spring with respect to outbreaks. Finally, on the right-hand side of this slide, you'll see that our reproductive number is above 1. And you'll recall that when this number is above 1, it means that the outbreak will continue to grow. Keep in mind as well that given that we have such high case counts, the continued growth means that you'll continue to see these large numbers, and you will see that unless we are able to increase distance and to get that reproductive number down, any number above 1 will continue to see growth and numbers that frankly we do not want to see. So it will take time to bring this down, but that time will be accelerated the more we are able to put into place those measures that we know that disrupt spread, the most notable of those being distance at this point in time. Turning to the next slide, we're looking at projections that show that Toronto will surpass ICU capacity before the end of January. This is a slide that's premised on a model provided courtesy of our friends at the Canadian Institute for Health Information. And I would say that one of the silver linings, if you will, of the cloud that is the pandemic is the nature of the partnerships and collaborations we've had with other partners, one of whom would be CIHI, that Canadian Institute for Health Information. The brief story with respect to this slide is that, we were trying to look at the different scenarios based on different reproductive numbers, given that we are all very concerned around hospital capacity and the impact that COVID-19 is having and COVID-19 spread is having on our hospital capacity. The issue, of course, is that in any scenario that we show here on this slide, we are on track to surpass the standard ICU capacity that's indicated by the dashed line here on the slide before the end of January. This simply emphasizes yet again how important it is that to the greatest extent possible, that we together as a community, each and every one of us as individuals, does our very best to maintain that distance with others, particularly maintaining distance from people with whom we do not live, in order to protect our health system to the greatest extent possible. Turning to the next slide, we're now looking at data in respect of our long-term care home and our retirement home environments. We know that these environments are home to amongst the most sensitive populations in respect of the most severe or serious outcomes related to COVID-19. And here in these graphs, we show the number of cases within the in long-term care and retirement home residents and the number of deaths as well. Briefly, the proportion of cases in long-term care and retirement homes who've died is lower in recent months compared to that which was seen in the spring, but still higher relative to overall case fatality. I do think that it is important to note that of the over 2,000 deaths, 2,206 deaths that we've had in Toronto thus far. You may recall this on the earlier slide. We talked about the case summary, but this is just a reminder that of the deaths we've seen in Toronto, approximately 64% are linked to an outbreak in long-term care or retirement homes. So I do think that you've heard this before. It still bears repeating. These settings continue to be most vulnerable to the most severe of outcomes. And hence, and we'll talk about this a little bit later, as vaccine becomes available throughout the entire province, certainly vaccination in this sector continues to be a priority in terms of its ability to assist us in preventing additional cases and certainly in terms of preventing future deaths. Turning now to the next slide. This is to give you a sense as to where we, how we are doing in respect of our COVID-19 experience. And in particular, we're looking at cases per 100,000 population over the last 2 weeks. So it's a regional comparison, Toronto versus some other jurisdictions, which I admit are national or nations rather than cities. The short version of the story here is that, look, amongst many jurisdictions, they have seen increases and surges in respective daily cases, and patterns that are similar to that which we are seeing in Toronto have been observed in jurisdictions around the world. Each jurisdiction manages it ever so slightly differently. Again, I think that's mindful of their own unique circumstances and certainly their own unique cultural approaches to how best to support appropriate behaviors amongst a population. But I think it's important to note that all the countries, all the jurisdictions that are represented here on this particular graph have had to move to some form of lockdown measure in order to drive cases down. And the degree to which those lockdown measures are stringent or not stringent does vary from one jurisdiction to the next. I think that there are a couple of important points to note, though. We know that it does take a certain number of public health measures to start to see the results in terms of fewer cases and pressing down COVID-19 activity. There is also, of course, a lag that's noted. As measures get deployed and implemented, it does take time before the effect of those measures is actually seen. And the final point that I would make in respect of this graph is that, while there have been similar patterns with respect to increases or surges in cases across a number of different jurisdictions, each jurisdiction does manage things slightly differently. Likely in response to their unique circumstances, whether they're geographic, cultural, behavioral, or a combination of all of those. So it speaks to the need for us to continue to monitor and measure and to think about how best we respond to the situations and the circumstances that we see arising within our community. Turning to the next slide, just a very high level summary in respect of some of the jurisdictions shown on the previous slide and the types of components and measures as part of their lockdowns that they undertook in order to control COVID-19 spread in their communities. And you'll see that there are some areas where there is clear harmony across jurisdictions and others where jurisdictions initially chose not to implement certain elements of control or certain measures, and then subsequently changed at a later point in time, again, in response to the circumstances that they saw in their unique situations. Turning to Toronto specifically, we'll look at the next slide. What you see here is a graph that depicts the weekly proportion of device time spent at home in Toronto. And this is for the period from January the 1st of 2020 up to January 9th of 2021. And, I won't belabor the point with this particular graph, but towards the right-hand side of the graph, you can see what has been happening by the blue line increasing or moving up the graph, indicative of the fact that the amount of time, the proportion of time that people's devices or cell phones were actually at home has been increasing. You'll note that that has happened in particular since late November, early December. So we can see that some of the measures are starting to have impact in terms of reducing mobility in Toronto, which is a good thing. This is exactly the kind of impact we were looking for. We know that COVID-19 spreads from person to person when they're in close contact with others, particularly those with whom they do not live. So certainly seeing this increase in device time at home gives rise to some optimism that the measures are starting to have some impact here in Toronto, at least in terms of mobility, and hopefully will manifest themselves in reduced viral spread and activity. I would note that obviously the period between December and January includes the holiday period, and that is a time when there is less movement, particularly between home and work. So that would account for at least part of the reason why there was more device time at home during those weeks of December. However, looking at data from the previous year, it would appear that there was an additional increase seen in device time at home over and above that which would be expected as a result of the holiday break. So again, more reassurance and at least a promising sign that the public is responding appropriately to many of the calls for staying at home and to the measures that have been deployed to date in order to try to control the spread of virus in our community. So turning to the next slide, just a high-level summary of the data. Clearly, significant impact of COVID-19. As of late, we have been seeing increasing challenges with respect to the demand on our hospitals and our ICUs, and certainly outbreaks and the demands that those place on long-term care homes. As I've just presented to you, there are promising mobility data suggestive of the fact that we are increasingly staying home. And what this all says when taken all together is that we do need to continue to follow public health measures. And in particular, we need to implement and think about public health measures with due consideration for equity issues and the differential impact that COVID-19 has had on subpopulations and different communities throughout our city. Again, it always bears repeating that the current stay-at-home order that has been implemented by the province must really be followed. It's part of keeping COVID-19 spread to a minimum in our city. And just reminders that, of course, for members of the public, if they are symptomatic, they should isolate and get themselves tested. There are options for those who do test positive to help them protect their families, considering isolation in a voluntary isolation center. And as vaccine becomes available over the course of the next several months, we would encourage people, and there will be measures to encourage people and to inform people appropriately to get vaccinated as their eligibility becomes available, or as they become eligible to receive vaccine. Next slide. So there are a number of recommendations made in the report. And of course, as the situation is constantly evolving, we have some further thoughts for consideration by the board, recommending that the province respond to the current level of COVID-19 transmission. First and foremost, by continuing to monitor the provincial circumstances and other evidence, and there are many other sources of evidence, the experience of other jurisdictions, our own historical experiences here, just to name a few. But these should all be taken into account and considered in terms of adjusting public health measures in order to control the spread of disease. And as well, starting to think more proactively as we start to think about a future, with COVID-19 vaccine over time becoming more and more available, and hopefully providing greater and greater protection to members of our city and the population writ large, proactively planning to reopen schools and other sectors safely, or as safely as possible, again, in keeping with the best available science and evidence on the subject. Turning to the next slide, this is a response to some questions and inquiries that the Board of Health had with respect to isolation supports for families. And by way of update, I can advise members of the board that the city, as part of the city's COVID-19 Equity Action Plan, has indeed consulted with community agencies in order to identify supports that are most valuable and useful for families, such that they can quarantine safely or isolate appropriately as the circumstances require. And this support includes access to appropriate isolation and quarantining facilities as needed, and these will vary from one family circumstance to the next. And we also found in the course of providing our supports to people that, and our case management in particular, I would say, delivery of food and essential items to the home are the kinds of supports that actually make the difference for many families in our community, allowing them to effect a proper and a safe either isolation or quarantine, as the case may be. Turning to the next slide, I will just provide a very high-level update, not with respect to the immunization clinics, but the other aspects of COVID-19 vaccination. This is a rather large undertaking. I won't get into great detail, but suffice it for now to say that the COVID-19 vaccination that has been undertaken to date has focused largely on long-term care homes and retirement homes, whether we're talking about residents, staff, and essential caregivers in these settings, and as well on other healthcare workers, particularly healthcare workers who are in high-risk situations, whether they're at high risk for exposure to COVID-19 or regularly deal with patients and clients who are at high risk for severe outcomes associated with COVID-19. And thus far, this has been a collaborative effort between Toronto Public Health, many hospitals in Toronto, and the long-term care homes and the retirement homes throughout the city. You likely have heard through the media that that Pfizer, the company that makes one of the most readily available vaccines to date for COVID-19, announced that they are retooling or making some capital changes to their factory in order to allow for them to scale up production. But in order to do those necessary, the physical changes to their plant in order to scale up production, they will have to temporarily slow down vaccine production. And what that means for us here in the province of Ontario is that there will be a 20 to 80% decrease in the delivery of vaccine over the next 4 weeks, unfortunately. This is, again, we understand to be a temporary situation in order to allow for that, that necessary tooling up of their facility to happen. And as a result of that, we are going to see that the main vaccination focus in Toronto, as is the case in many other jurisdictions around the province, will be on completing the vaccine series for those who have received dose 1 thus far. And that includes long-term care homes, retirement homes, and healthcare workers, as I articulated earlier as part of my explanation on this slide. So this work will continue. We are doing our very best to work with our partners to ensure that, you know, while there are limits in respect of vaccine supply, that vaccines are in those circumstances being provided and administered to those individuals where the greatest value can be provided, where those who are greatest risk for negative outcomes and serious outcomes, including serious illness and death. So with that, I will turn it over to Chief Peg as he will walk you through a little bit more around the COVID-19 vaccine rollout and what it is that we are doing for immunization clinics here at the City of Toronto. So over to you, Chief.
Thank you, Dr. Davila. My audio is okay, I assume? Okay. Chair Cressy and Vice Chair Wong Tam and members of the board, good morning, and thank you very much for the opportunity to allow me to join you today and give you an executive overview of sorts of the hard work and good work of our immunization task force. The slide in front of you is important, and it really details out the unwavering reality that in order for us to be successful in the COVID-19 immunization campaign, we require the continued coordinated work of all 3 levels of government. And it's worth just noting for the record the way that this system works. The Government of Canada federally is responsible for approving vaccines, then procuring them and distributing them to the provinces. So that's the federal government. Once vaccines are received from the federal government, it is the province who are responsible for receiving those approved vaccines from the feds, and then the province establishes the vaccine distribution priorities and ultimately distributes the approved vaccines across the province. Once the City of Toronto is provided with or has access to those vaccines, we are then responsible for administering the vaccines in accordance with the ethically informed prioritization framework that has been developed by the province. So there's a clear partnership in play, and one that has informed and continues to inform everything that we do. Next slide, please. So I'm very proud of the fact that Toronto has been proactive in our response to COVID since the very outset of the arrival of COVID-19, and in fact, since the arrival of what was then still referred to as coronavirus in the City of Toronto. We established our incident management system way back, what feels like a lifetime ago now, and proactively established our immunization task force in November. And I think it's really credit to the Board of Health and to Dr. Davila and the Toronto Public Health team that we did, in fact, as a city, start and launch our immunization task force, or ITF as we refer to it, ahead of any request to do so. And that's just indicative of the continuing proactive nature of our response. It is my pleasure and privilege to lead that task force in addition to my role as the city's COVID-19 incident commander. So really, I won't go through all of the points, or certainly won't read them to you, but the overarching responsibility or role, if you will, of the immunization task force is to provide every possible support and assistance to Dr. Davila and the Toronto Public Health team with respect to responding to and actioning the various objectives in response to COVID-19. We work directly in collaboration with the province. I work directly in collaboration with General Hillier, who, of course, as we know, was appointed by the Premier of Ontario to lead Ontario's vaccine distribution task force. So we are in direct contact with them. And of course, everything that we do, as Dr. Davila said, is highly dependent on what is becoming and unfortunately is a highly variable situation right now relating to the availability of vaccines. Next slide, please. So important to note, again, there's a lot of information on this slide. I certainly won't go through it all. Important to note, and what's most important to me is that Dr. Davila, in her role as Toronto's Medical Officer of Health, is the authority having jurisdiction with respect to the response to COVID-19 pandemic in Toronto. My particular subject matter expertise, and the reason that I appear before you today and have been involved, my specific expertise is in managing complex emergency incidents and developing and then implementing and operating the incident management systems that we rely on and that we use every day to guide our response. I was asked to assume the COVID Incident Commander role in March of 2020. And as I said previously, the role of now the Immunization Task Force and our entire team, we really exist to ensure that our Toronto public health colleagues have the resources they need to get their critical work done. So in an overly simplistic means, my team becomes a focused, dedicated set of hands, if you will, that Dr. Davila is able to deploy, and our team is hard at work. As your incident commander for COVID-19, I am ultimately accountable for delivering the objectives and for achieving the tactical priorities that were set at the very start, which is standard process for any incident management system. And then ultimately, I'm responsible for directly supporting the needs of both Toronto Public Health and Dr. Davila, and of course, the entire Toronto Public Health team. Next slide, please. So our Immunization Task Force reports directly to our city's COVID-19 Strategic Command team. We structured it, the task force is structured as any standard incident management system structure permits. And that means that the ITF, we created a command team that operates our Immunization Task Force. I chair that in my role as the COVID Incident Commander. And it includes, of course, Dr. Davila as the principal authority having jurisdiction. And we are joined by City Manager Chris Murray, Chief Communications Officer Brad Ross, and the City Solicitor Wendy Wahlberg on that command team. We also have what we refer to somewhat loosely now as a project management team. That is a small team of people who are dedicated primarily with supporting the delivery of the objectives identified by Dr. Davila and her team. And of course, Dr. Michael Finkelstein, we are in more daily contact with, almost regular contact. It is Dr. Finkelstein and his team who provide the medical subject matter expertise and lead the production of all recommendations with respect to medical oversight and vaccine administration. So as I explained before, really the role of the Immunization Task Force is to be additional sets of hands that folks like Dr. Finkelstein are able to access. We have a number of key supports, health and safety information liaison. They're all fairly standard. Most important, and I'll summarize this slide by saying this, we are operating the Immunization Task Force under the same principles that we operate the COVID-19 incident management system under, and that is, it is a robust system, it is scalable, and is proving to be highly effective. And that this is the same, important, maybe interesting for you to know, these are the same processes that we implement thousands of times a year in response to emergencies that occur over across the city of Toronto. This, of course, is just much more significant and much larger and more complex. Next slide, please. So importantly, with respect to immunization clinics, our work, as I said back in early November, our work began in earnest in creating an immunization clinic plan. And I'm very proud of the fact that we have a robust plan that is still under development and still, some additional work is required and ongoing, but we have a robust plan in place. That plan for Toronto will include, at the appropriate time, the launch of a network of immunization clinics across the city of Toronto that will ultimately and concurrently be supported by both a series of mobile clinic operations and targeted priority neighborhood community response teams that will help us support directly some of our most vulnerable communities, and my colleague will explain some of that work. The way that clinics are envisioned to operate, or there's a niche space, if you will, that within the provincial framework and the provincial plan, clinics are designed to operate within one particular space, and that is in that area between the point where hospitals begin to immunize high-risk populations, which, as you know, and Dr. DeVille spoke to, is currently ongoing, and the point at which vaccines become readily available to anyone who wants to receive them by way of agencies and folks like primary care physicians and pharmacies. So by no means are the immunization clinics the sole means by which Torontonians will have access to vaccine. They are one piece of a very complex and very robust plan. We said we are looking at or working on setting up multiple immunization sites. From a timing perspective, the province asked us initially to be ready to launch our first clinics on or about April 1st. We understand that that date remains very fluid, and that is directly tied to the availability of vaccine. We are, as evidenced today, and we'll talk about this in the next slide, we as a city, under your leadership as the Board of Health, and certainly under Dr. DeVille's guidance, accelerated our plans. And our overarching goal, my overarching goal as your incident commander, has been to make sure that we are as prepared as possible and that we are as proactively positioned as possible, such that we can accelerate and turn things on, if you will, the moment that the province is able to make vaccine available to us. So we've done a good job with that. So the moment we get word from the province at any point in time that we are good to go, so to speak, we will be in position to launch and to increase our provision of clinic operations across the city. Next slide, please. So obviously, good news today. So in response to a request that came from the province, we are in fact accelerated and have accelerated the launch of one clinic, which becomes the first clinic actually, not only in Toronto, but across the province, to operate in a non-hospital setting. And that clinic is opening in a few short minutes, actually, at the Metro Toronto Convention Centre. It is an accelerated, what we're calling a proof of concept clinic. And the province, through General Hilliers' leadership, asked the City of Toronto if we would stand this clinic up in a very scaled model in order to undertake the proof of concept analysis and evaluation of every aspect of clinic operations. And that means that we are looking at not only the design and the setup and the operation, but all of the technology, all of the registration, everything to do with clinic operations from one end to from all the way through to completion. We will then, based on what we learn, we will author and submit to the province what is referred to as the clinic playbook. And based on all of that work and experience, we will work with the province to author what will become the playbook and the manual that will be provided to all of the other municipalities across the province of Ontario, thereby enabling a couple of things. Firstly, it will enable us as a city to stand up our additional clinics and get them running, and of course, stand up the remaining clinics across the province. The initial proof of concept clinic that's operating today is operating on a dose, on a capacity, if you will, based on 250 doses per day. I want to be very clear that that's operating at approximately 10% of what we calculate or what we know the capacity of our clinic to be. So by no means are we saying that 250 doses a day is our target. We know we can do exponentially more than that. We are throttling, so to speak, the initial proof of concept clinic based on the availability of vaccines. The folks that will be participating in this initial proof of concept clinic are healthcare workers on the very front lines of COVID-19 in support of some of our most vulnerable residents. And that is including frontline healthcare workers in the shelter system, including both harm reduction workers and streets to home workers. So that is, they're amongst the group that will begin to receive their vaccines in about 40 minutes from now. So that clinic is fully scalable. We can scale it up, we can scale it down, and at the point where there is additional vaccine available, we will happily scale this clinic and any other clinics up. So that concludes my slides. I will end my piece just by expressing my sincere thanks to all of you and to Dr. Davila and our Toronto Public Health team for your continued confidence. This is a daunting task, to be candid, but I will say that it is my distinct honor to serve in this role and to work alongside Dr. Davila and each of you in the amazing Toronto Public Health team as we continue to battle what is undoubtedly the most daunting or the most pressing public health issue in our generation. So with that, I will say thank you and hand back to Dr. Davila.
Thank you, Chief Peg. We're going to continue on with the presentation, and the next few slides will be presented by Anania Grant. So let's move to the next slide. And Anania, are you there?
Yes, I'm here. Yes, I'm here.
Perfect. Welcome. Thank you. I'll turn it over to you.
Thank you so much, Dr. Davila. I want to make sure that everyone is hearing me. We're good? Okay.
You're loud and clear, Anania.
Awesome. Thank you. So thank you, Board of Health. I'm really happy to be able to share that Social Development, Finance, and Administration is implementing a grassroots strategy to address vaccine misinformation in communities most impacted by COVID-19. This is an extension of the COVID Equity Action Plan, which you heard about by Dr. Davila and Chief Peg, that we established and shared with you at the December 14th Board of Health meeting. The strategy focuses on mitigating vaccine hesitation in populations and neighborhoods with historical concerns related to vaccination. Neighborhood resident leaders and community agency and grassroots groups, including faith-based leaders, and are being mobilized as we speak to engage with their community because their communities trust them. Communities trust their leaders, they trust their on-the-ground leaders, they trust their community agencies, and so the city is securely partnering with these agencies and these grassroots organizations to make sure that we're able to engage community and mobilize community. Our goal is to ensure that there is an understanding, we address the concerns and address the hesitation to vaccination. We want to ensure that we engage specifically Indigenous, Black, and racialized groups and households that are low income, because we want to make sure that they understand the information, that we're able to debunk some of the misinformation, and that we're able to share the information in clear, understandable manner that people can understand. In combination with grassroots media strategy, SDFA has created a subject matter expert task force with Black community members who are specialists in the development, regulation, and distribution of vaccines, as well as specialists in knowledge translation, who will convey scientific concepts that I spoke about earlier, scientific concept information into understandable ways so that residents can understand and can participate and can trust the information. These experts have worked extensively in these fields for decades across the country and around the world, and can engage networks to reach various communities within the city. Toronto Public Health will absolutely be supporting these individuals with materials, messages, logistics, any requirements that is needed, and we're working very, very closely with our corporate strategic communications group as well to make sure this happens. Next slide, please. We've shared with you a list of the task force members for your information and for you to see the caliber of people that we have engaged. And as I said, TPH is definitely involved. So TPH leaders are involved, Dr. Finkelstein and Dr. Lamptey, as well as Nicole Welsh from TPH and myself. And it is being led and co-chaired and chaired by Dr. Kwati Kente, who the city has engaged as our strategic advisor and consultant on not just vaccine, but the overall COVID COVID equity plan. The task force goal really is to address Black community concerns with COVID-19, the COVID vaccines, and key reasons for vaccine hesitancy. Secondly, to develop corrective science-based knowledge that is culturally tailored to address key community concerns, risks, and vulnerabilities. To develop and disseminate policy recommendations that effectively close race equity gaps in current vaccine planning and strengthen Toronto's vaccine outreach to Black and racialized groups, and of course to Indigenous populations. We hope that this will drive positive messaging about Toronto's COVID equity action plan and the resources that clarify mixed COVID messaging and promote testing and safety practices. The next slide. So in partnership with the Toronto Public Health, as I mentioned before, shelter, support and housing, and strategic communication, we're working to ensure that we have intentional and relevant engagement and mobilization to give access to all Toronto residents to the COVID vaccination. Because as you know, we could set up clinics all over the city, but if people don't know how to access them, if people are not feeling that they can trust the system, that they can trust the messaging, and that they can trust that Toronto as a city, as a government, is really looking at making sure that we save lives, then no one will go, then people won't go. So we're making sure that the way we have framed our mobilization plan is, as I mentioned before, to leverage on the equity plan that already exists. That is that we develop a wraparound support and support those who are affected most by COVID. As we move into the vaccine rollout, we're expanding the engagement and activities in implementing the city's immunization engagement. We are collaborating with community to enhance promotion and accountability through the deployment of this process. We're taking a resident-centered approach. We have to work with community to make this happen. We are working with community on the promotion, but also on the championing. And we will use general COVID educational sharing and testing promotion to socialize our residents to vaccine receptivity, while of course acknowledging and recognizing the ethno-racial diversity and inclusion, especially Indigenous, Black, and racialized community, but also our persons with people with disabilities, and where we're seeing a rise in COVID contacts. So South Asian and Central American populations. We are going to work right across the city and make sure that we engage those who are most trusted. Much of our work will focus on building trust. I have to tell you, that is our focus. Building trust and building confidence in the city's efforts to save lives and the recognition of systemic racism. We must move forward with this framework with vaccination, mobilizing engagement, ensuring that the city recognizes anti-Black racism, anti-racism, anti-Indigenous racism right across the city, and make sure that we're prioritizing life-saving efforts in this community. I thank you so much for allowing me space and time to share this with you as we begin the engagement and mobilization of work.
So thank you, Anania. I very much appreciate that. So thanks to you and to Chief Peg for your presentations today. And if I may, for your collaboration and partnership throughout this historical immunization, I should say, undertaking that we are taking on together. I would just say, if I could just take a few minutes, Mr. Chair, the thanks really applies to far too many colleagues to name across the entire city. So, you know, as we wrap up this presentation, I would say the best that I can do right now is to offer a blanket message of thanks to the many city partners who have been helpful to us, to myself and the team at Toronto Public Health throughout the entire response. I would like to take this very brief moment to thank the Board of Health, for their ongoing support. And a special thanks to you, Mr. Chair. You've been an active support to me and to the entire team at Toronto Public Health since day one. And it's on that subject of day one, right, that I think about right now. Today is January the 18th. So it has been almost exactly 1 year since that first COVID-19 case presented here in Toronto. And I would say this to members of the board. It has been a truly incredible year that has tested every aspect of the team and the entire team here at Toronto Public Health. And perhaps it's even gone beyond that. And, you know, you've heard me say this before, but it does bear repeating that, you know, we have faced no end of challenge in the last year. I can, you know, think of a myriad of challenges. We're thinking about a novel virus about which we were actively learning as we were responding, incomplete information, evolving evidence, compressed timelines. And these are just a few of the challenges that I think of as I think back on the last year that has been basically occupied almost completely by our response to this pandemic. But no matter what the challenge, I continue to be impressed by, you know, the professionalism, the dedication, the skill, and the commitment of every single member of the team at Toronto Public Health. I wish I could name each and every one of them and acknowledge each and every one of them for their contribution to our response. But unfortunately, we don't have that kind of time. So the best I can offer is, you know, a heartfelt thanks to the entire team. Now a year into this response, now with a new aspect, both hopeful in terms of vaccine, but also with much yet to do in front of us. So, you know, my thanks to the team and my encouragement to them to continue on with the excellent work that they have done in service of the people of Toronto. So with that, Mr. Chair and members of the board, thank you very much for your attention. I will now turn the microphone back over to you, Mr. Chair.
Well, thank you, Dr. Davila, Chief Peg, and Anania Grant. Members of the board, we're going to move to public deputations before we bring it into committee for questions of city staff, of which we have many here today in Toronto Public Health staff. Our first speaker, and there are 5, is Caleb Elias. Do we have Caleb on the line? To our recording secretary, I'm not sure. Do we have Caleb on the line?
We're just double checking, Mr. Chair.
Okay, I'll ask you to do one final test and then we'll hold that down in case we get him later.
Yes, it doesn't appear like he is on the line. Fortis, can you confirm?
All right. Public deputations in the era of virtual meetings is not the easiest. So Caleb, we will make a note that if you rejoin, I will try coming back to you. Our next speaker is Diana McNally from the Toronto Drop-In Network. Do we have Diana on the line? To our clerks, can you confirm?
10 second speakers are not present.
Okay, so neither are present at the moment, so we will return to both of them if they join. Our next speaker is Josephine Petcher from Unifor. Do we have Josephine on the line?
Josephine should be present. I'm just going to unmute her system. One moment, Mr. Chair.
Josephine, do we have you? Could just going back to the clerks, Division, could you indicate, please, if you have opened the line and if Josephine is there? Julie or Fortis, I'm looking from clerks. I'm looking to you to indicate the status, please.
My
Mr.
apologies,
Chair, it
Mr. Chair.
appears that Josephine, yeah, it appears Josephine
I'm
is
just having a
connected,
little
but
bit
her
of technical
audio.
issues.
So hold tight, everybody. And Fortis from clerks, could you just advise if we are holding on Josephine, or whether I should be moving to the next registered speaker, please?
Yes, Josephine is online. I just need a moment to unfreeze my system. My apologies, Mr. Chair. Okay, Josephine, I believe you are now unmuted.
Yes. Hi, can you hear me?
We have been waiting anxiously. I cannot express the anxiousness. Josephine, you'll have 5 minutes. So, and thank you, Fortis. Josephine, you'll have 5 minutes. I'll give you a heads up at about 4 minutes and 30 seconds, just for a time check for you, but you can begin when you're ready.
Great, thanks so much. Good morning, Chair and members of the board. I want to thank you for the opportunity to offer this deputation. My name is Josephine Petcher. I'm the Toronto Area Director for Unifor. That's Canada's largest union in the private sector. Unifor represents approximately 315,000 workers across the country, with over 24,000 of them working in the city of Toronto, including at restaurants, hotels, supermarkets, factories, warehouses, as well as in telecommunications, media, healthcare, and many other sectors. I am here today on behalf of Unifor's National President, Jerry Dias, and our Ontario Regional Director, Noreen Rizvi, to support the recommendations provided in the Chief Medical Officer's report dated January 5th, and specifically her recommendation urging the province to mandate paid sick days for all. As board members know, paid sick days is a long-standing demand of worker and health advocates across the province. After extensive consultations in 2018, the provincial government introduced legislation mandating that all employers provide a minimum of 2 days of paid leave for workers. Unfortunately, these changes were short-lived, despite being very well received across Ontario, certainly thousands of our members, especially those in low-wage and precarious jobs. And take supermarkets, for example. Despite being a heavily unionized sector, collective agreements are not immune from broader economic pressures. Today, about 80% of supermarket workers work part-time, most with no guaranteed hours of work, no set schedules, most at or near minimum wage, like most in the retail sector, and no paid sick days. But a generation ago, 80% of these folks were full-time, enjoying stable schedules and strong benefit packages. Despite extensive efforts, it has proven difficult to negotiate paid sick days for supermarket workers. And, employers say, these are added costs. It puts them at a disadvantage with their competitors. Why should Metro do this if Sobeys doesn't have to? Yet many of these same employers actively lobby against legislative efforts that would create a common standard and level the playing field. For too long, these employers have had it both ways. And I'm using supermarkets as an example, but the grocery industry, it's just one part of the larger economy. It is not much different in hotels, long-term care homes, warehouses, restaurants. The transition away from stable jobs is happening everywhere. Today, only half of the workers in the GTA and Hamilton area are in stable employment. The rest are in some form of precarious work, particularly women and workers of color. And the situation we face today is unlike anything we could have imagined in 2018. The same workers who were stripped of those paid sick days are now the ones on the front line, the essential workers who can't afford to lose a day's pay. Because unfortunately, having little or no paid sick leave can be a deterrent for reporting and self-isolating for workers everywhere. This is particularly important during a pandemic for reducing spread among coworkers, their families, and the public. Maybe they deal with customers. that it is always important for public health for sick people to stay home. Unifor is tracking nearly 300 active COVID cases right now among our members in Ontario, many of them in high impact sectors like healthcare. And each week, these figures get worse. What we've learned is that it takes a collective effort to combat the virus, and it requires us having the right policy tools for the job. Paid sick days is one of those tools. Telling workers it's okay to stay home if they're sick is simply the right thing to do. We support Dr. Davila's call for up to 10 days paid sick leave. And in fact, we encourage you to consider extending that to 14 days, a recognition that for many workers, the 5-day work week doesn't exist if you're in a precarious sector. Momentum is building among city politicians on this matter, and that's a good thing. But like on so many matters, we need Toronto to lead, and that starts with a favorable vote today. Thank you for your time, and I look forward to any questions.
Thank you very much, Josephine, both for the presentation and the patience as we got you connected. I'd ask you to hold on for a second and let me open up to members of the board. Are there any questions for Josephine? And I just note I can't see everybody on my screen, so if you have questions, if you just want to unmute your mic and indicate your name.
It's Kristen, Councillor Wong Tam.
Councillor Wong Tam, over to you. You'll have 5 minutes.
Yes, thank you, Mr. Chair. Josephine, thank you very much for your deputation. Just out of curiosity, I mean, obviously there has been quite a bit of resistance from the provincial government on this particular matter, one that is crucial in helping us curb the transmission in the workplace. But one of the responses from the Premier, and he's repeated it several times, is that the federal government has introduced the Canada Recovery Sickness Benefit. In your opinion, how does that particular federal benefit fall short of actually ensuring that people can stay home when they are feeling sick?
Thanks for the question, Councillor. I think it's a great question. I point out that it's certainly a great floor. It's important to have it, absolutely. But it provides $500 a week. So for many, that's a minimum wage pay. For many workers, this is an expensive city, struggling to make ends meet, pay rent, pay mortgage, raise a family. That's going to cause a lot of economic difficulties. It's also in blocks of time. So, it may help in some situations within the pandemic, not for other amounts of, not for other types of leave. It's, in 5-day blocks. And, what we're looking for is something that's complementary to that. We're not looking to replace it, but we don't actually think it's comparing apples to apples.
Thank you. So the recommendation that has come from the Board of Health, this is not the first time that we're asking very politely for the province to create this program, but the recommendation from the Board of Health has been repeatedly, I would say, dismissed by the province. Is it your opinion that if people cannot stay home while they're feeling sick, that they are directly transmitting and causing further risk to co-workers and clients or perhaps customers of theirs that they have to interface with? Like, how critical is this provincial program that we're asking for going to help us with the curb of the transmission?
I think it's pretty critical. I think it's something that we can take note of in all sectors and in all types of work. If it's going to be a financial penalty, and among other things, it can take up to 4 weeks to get it. People can't afford to. I mean, people are worried about evictions, not making their mortgage. If they're going to take a big financial hit and a huge delay, which they can't afford to, it's a deterrent from reporting and self-isolating.
Thank you. And would you say that without this program, without the provincial program for paid sick leaves, we will not be able to stop the spread of transmission?
I think so. I would agree with that.
Thank you very much. Thank you, Josephine. Thank you.
Thank you, Councillor Wong Tam. Are there any other members of the board with questions for Josephine? Okay, seeing none, Josephine, thank you very much. I'm now going to switch back to Fortis and Julie from our clerk's department. Our next speaker is Josh Fullen from Maximum City. Do we have Josh on the line?
Oh, I'm here, Chair Cressy. Can you hear me?
Josh, I hear you loud and clear. And Josh, you've been here before, and we're grateful for that. So when you're ready, you can begin. You have 5 minutes.
Thank you, Chair Cressy and members of the board. My name is Josh Full, and I work for an organization that has been studying the overall health and well-being impacts of COVID-19 conditions on children and teens. And the point of my deputation today, unlike previous deputations, is not to share results, but to share a tool with you. So we have developed a risk assessment tool for worsening well-being. And I'll speak to that in a moment, but I actually want to highlight something from the analysis that we've conducted since our last deputation. And that's the fact that there are 3 modifiable behaviors that are associated with better health and well-being outcomes for children and youth. And those 3 behaviors are physical activity, time outdoors, and social interaction, including through a screen. So the good news about those 3 behaviors is that, first of all, none of them contravene a stay-at-home order or the public health guidelines, at least as I understand them. And they're also within the control of individuals. So all of those things are things that kids and teens can implement in their daily lives and their daily behaviors right away to make a difference. And we know that they are associated with better health and happiness outcomes based on our analysis of 10 months of data collected across Canada. So that's physical activity, time outdoors, social interaction through a screen. Today, the point of the deputation, as I described at the outset, is to share this well-being risk assessment tool. And this tool is a response to 2 things. There was a demand for it when we shared our materials and our data and our findings with bodies like this one and with parents. They asked for something practical that they could use in their daily lives. And we also think this is a good tool that can be part of a school reopening plan whenever that takes place to right-size healthy behaviors, because we know that there is much more sedentary behavior among children and youth because of the pandemic conditions. So essentially what this risk assessment tool does is it takes all of the information, all the data and analysis that we collected, it pairs it with the Canadian 24-hour healthy movement guidelines, puts it into a funnel, and if you answer the 20 questions in the survey questionnaire, it takes about 3 minutes, you will get a score out of 100 and a risk level out of 5 quintiles. And you will also get recommendations targeted based on the responses to improve your health and well-being outcomes based on the evidence that went into sort of the risk conceptualization and the framework that we've developed. So it's not medical advice, it's not a diagnostic by any means, but it does have a strong evidence base, as I said, to help young people, to help families right-size their healthy behaviors during COVID, when they're going back to school, when we're reopening. All of these things are factored into the risk framework and the score. So in the package that I circulated, I'll just orientate you quickly to that and then take any questions. There is a little introduction into the tool itself. There's an example of the result screen that shows you the risk level, the recommendations, and then the overall sort of scoring breakdown. And then finally, there is a table that gives you just a little bit of a sense of how we conceptualize risk, the framework that went into it. And then there's my contact. If you have any questions, the link to the risk assessment tool is maximumcity.ca/COBRA. And I thank you for your time, and I'm happy to answer any questions you might have.
Thanks, Josh. Let me open the floor for questions. And I can't see everybody, so if you want to unmute your mic to indicate, but I do see Director Peter Wong. Peter, do you want to kick us off there?
Sure. Thank you, Josh, for your presentation. And it's always enlightening to hear that we are focusing on children because I think that they probably are the group that is most impacted by this COVID pandemic. My question to you is your risk assessment tool. Do you have any specific areas in which you can make it easier for vulnerable populations to be able to access your risk assessment tool? Because we know that these populations have much more difficulty accessing the internet, have lower health literacy, and also suffer from more health issues. So just a question around vulnerable populations. Thank you.
Thank you for the question, Director Wong. You know, it was part of our sort of methodology to include exactly what you just described. We are working with partners in Northwest Toronto, North Etobicoke, the Rexdale Community Hub, to get this into neighborhood improvement areas within sort of their catchment area. The challenge is exactly as you described. If you're not online and you don't have facility with completing a survey in English and French, which are the two languages that we had the capacity to develop the survey tool in, it's very difficult to get someone to answer it. So what we're doing is we're actually using more of a qualitative method in the coming months to get it into the hands of folks in Rexdale, in Northwest Toronto and Northern Etobicoke, so that they have an opportunity to complete it. And we're actually using youth, high school students, to disseminate it to other high school students. So we're using kind of a peer-to-peer model to connect folks with the tool, and they will actually facilitate completing the survey with their peers, with other youth. So that is the model we've developed. Unfortunately, we don't have the capacity. We're a small shop at Maximum City. We don't have the capacity to do that right across the country or across the city, but that's what we have in mind.
Thank you, Josh.
Thanks. Are there other members of the board with questions for Josh? Seeing none, Josh, I just have one. So you spoke to 3 modifiable behaviors important to improving health during this period. So physical activity, time outdoors, and social interactions, including via online. I guess the question would be, when you look at the programs underway in Toronto right now during this lockdown period, whether it's the continued opening of winter activities under safety protocols, you know, efforts to address the digital divide by getting devices into the hands of those who might not have it, or, you know, virtual programming from TPL and others. Are the current efforts undertaken by our city sufficient, or are there others that you feel should be improved to deal with that, to address those modifiable behaviors in a positive way?
It's a big question, Chair Cressy, and I think what I've seen from the city addresses a lot of those deficits that we're seeing. I think there is more that school boards could be doing. I think school boards are sort of the natural allies for this kind of work. So I've been sharing this with sort of the large school boards in Southern Ontario as well. I think the real work to be done there is, as we reopen schools, we need to get kids to right-size their healthy behaviors, and that the best way to do that is through schools, because they have a captive audience of young people, and they can have sort of the most day-to-day impact on the healthy behaviors of children and youth.
Well, thank you for that, and I know I will just, as a side comment, I know Trustee Donaldson is in the process right now of convening a working session between the 2 school boards and Toronto Public Health as we look towards when the safe reopening occurs and how we improve the health as part of it. So that's a helpful point. Are there any other members of the board with questions for Mr. Pullen? Okay, seeing none, we're going to our final registered speaker then today. Thank you, Josh. So I'll turn back to Fortis and Julie from our clerks department to tee up our final speaker, who is Derek Moran. Derek, he's been here before. Derek, do we have you on the line?
Yeah, hi, can you hear me?
We can hear you loud and clear. Derek, you'll have 5 minutes and you can begin when you're ready.
Okay, I'm just going to start my timer here. Just want to say, by me speaking at this meeting, this shall not be deemed to be in any way my consent expressed or implied. In doing so is fraud. God bless Her Majesty the Queen and long live Her Majesty the Queen. So in this report it says, residents who have tested positive for COVID-19 are required to isolate under a Section 22 order from the Medical Officer of Health under the HPPA. As Dr. Davila has said that her health advice is based on the science, that being the evidence, the scientific literature, peer-reviewed studies, I wanted to share with her this peer-reviewed article I came across from the BMJ, that's the British Medical Journal. It says, cycle threshold values from PCR tests are not direct measures of viral load and are subject to error. The only test for live virus is viral culture. PCR and lateral flow tests do not distinguish live virus. No test of infection or infectiousness is currently available for routine use. Unusually in disease management, a positive test result is the sole criterion for a COVID-19 case. Normally, a test is a support for clinical diagnosis, not a substitute. Testing should be reintegrated into clinical care with clinical and public health oversight and case definitions based on clinical diagnosis. Again, not solely based on a lab test. So in this report, it also says, these restrictions remain in place in response to the continuing significant rate of COVID-19 spread in Toronto. So this is from the same BMJ article. Searching for people who are asymptomatic yet infectious is like searching for needles that appear and reappear transiently in haystacks. The absence of strong evidence that asymptomatic people are a driver of transmission is another good reason for pausing the rollout of mass testing in schools, universities, and communities. A citywide prevalence study of almost 10 million people in Wuhan found no evidence of asymptomatic transmission. So the Ontario Divisional Court recently alluded to Dr. Davila in a recent decision dated this past December 23rd in Hudson's Bay Company versus the Ontario Attorney General, where the court said, one affidavit was sworn by a Toronto medical officer of health who explains her support for the lockdown restrictions, given the significant increase in rates of COVID-19 in Toronto. She makes the point that although known transmissions from shopping and retail stores may be low, the source of almost a third of community-based transmissions are simply unknown. To explain this unknown, Dr. Davila refers to in her affidavit, I provide the YouTube link in my written presentation of Dr. David Williams with Dr. Yaffe and Dr. Davila sitting next to him at one of those media Q&As answering a question on the wearing of masks, where Dr. Williams says, our protocols with respiratory conditions throughout the season, we have never recommended the wearing of masks in public. One of the problems with wearing the mask is, as both Dr. Davila and Dr. Yaffe alluded to, is I see people wearing the mask and then they're handling stuff and they put their hand on their mask and they touch their mouth and they do everything like that. It may give that person some solace, but if you're going to do that kind of respiratory protection, it's more important that you don't put your hands up to your face and mask, which I just did, sorry. And the mask may not be cleaned on a regular basis, so you actually may be recirculating stuff. So there's a lot of things about the handling of that, the same as you do in the hospital. You're very strict about how people wear them and change them and handle them, how they put them on and take them off. So it's not just a clothing thing to do because it's just to be used for very specific purposes in a specific timeline and disposed of and handled accordingly so. I understand that some groups like to do that if they want. That's their prerogative, but we have never recommended that in Ontario. And I just wanted to point out to all of you that based on what Dr. Davila said in her affidavit, that almost a third of community-based transmissions are simply unknown. Well, that's the unknown. People are
just
unwittingly...
time check that you have 30 seconds left, Derek.
People are unwittingly, as I've explained to the police board over the last 3 months, a whole bunch of more of this stuff. Mask use is a source of infection, leads to an increase in infection, and spreads the virus. And so now you've all found out just where the unknown community spread's coming from, is from the wearing of masks. And that's my time.
Thank you very much, Derek. Let me open it up to members of the board. Are there any questions for Derek? Okay, seeing none, thank you. I'm going to go back. Thank you, Derek. I'm going to go back to our team at clerks to see whether we were able to connect with Caleb or Diana, who had registered to speak, but were not on earlier. Do we have either of them back on the line for us?
Mr. Chair, the two speakers are not present.
Okay, so that's members of the board. That's our list of public speakers. So we're going to bring this into committee. So we'll start with questions of staff, and then we will move into speakers. I would note, so Dr. Davila and her team are here. Of course, we have Chief Peg, Anania Grant, and I would note we also have Tobias Novogrevsky from Toronto Employment Social Services on paid sick leave as well. So members of the board, could you indicate if you have questions, and I will add you to the list. And again, I can't see everybody, so I have Councillor Bradford, I see, Director Mulligan, Councillor Ainsley, and then Layton. Other members of the board? Okay, we'll start with that, and then I'll do another
Mr.
call.
Chair, I see Councillor Wong Tam as well.
Thank you, Dr. Davila.
Thank you.
You're welcome.
Okay, so we will begin with our brand new member, Councillor Bradford. Over to you. You have 5 minutes when you're ready.
Thanks very much, Mr. Chair. And it's great to be here with all of you this morning. Big thanks to the board and Toronto Public Health for all of your hard work over the past year. It really has been remarkable, and we're in a much better position today because of all your efforts. So I'm grateful for that. As the new one of the new councillors and board members here in this virtual room, I have a few questions about some of the vaccination work outlined earlier by Dr. Davila and Chief Peg, and specifically how we're going to be rolling out the mass vaccination as the supply increases. I know there's a lot of challenges with that right now, but I'd like to just take a little bit of a deeper dive for my understanding. The slides had really good clarifying information, which was helpful for me on the roles of the city's immunization task force and Toronto Public Health. There was a slide in the deck that had those sort of two roles and responsibilities outlined. But could you help me understand, I guess at the highest level, who is actually responsible for coming up with the overall plan for max vaccination? I know that different agencies and groups are doing different things when we look at long-term care or the general public. But is for the overall plan, is that the city via Toronto Public Health? Is that the city via the Immunization Task Force? Is it the province who is signing off on the city's plan? Is it the Ontario health teams or some combination of that? I'm just trying to get clarity on that piece. Who's responsible for the overall plan for max vaccination?
So through the chair, I will try to answer your question, Councillor, in as straightforward a way as possible. It's a rather complicated circumstance, but let's start off with this. First and foremost, the overall framework is the responsibility of the provincial government, and that includes the overall prioritization framework. However, as vaccine needs to be distributed and administered in local communities at the ground level, if you will, that's where local agencies come into play. And in particular, that's the role of local public health. So we basically take the overall prioritization as provided by the province. They will, for example, indicate in the first instance, they talked about healthcare workers in long-term care homes. That was the first group that was really eligible. That was manifested and administered through hospitals just because of the specific storage requirements on those vaccines. However, as we expand to more and more populations, the groups get larger, local public health gets more involved, and we have been asked to take care of the local prioritization and the implementation of their overall prioritization framework. I would also say this, as the supply becomes a little more available, the hope in the long run is to start to take advantage of the existing immunization infrastructure. So for example, you may recall that through the flu campaign, yes, the federal government is responsible for, doing things like ordering vaccine and procuring vaccine. The province orders in turn from the federal government. And what happens is that it is then distributed locally. So for example, local public health has immunization clinics for flu, community immunization clinics, but a goodly proportion. In fact, when it comes to flu, the majority of flu vaccinations are given through primary care providers in the community and pharmacies. So there's a pretty significant immunization infrastructure, and the plan on the go forward is for that entire infrastructure to be leveraged. So a combination of local immunization clinics run courtesy of the Immunization Task Force in Toronto Public Health, the Immunization Task Force being the logistics and support in order to allow us to do that work at Toronto Public Health, and as well through other immunization partners. So to date, we've seen hospitals, and in the future, I anticipate that we will at some point see primary care providers and perhaps pharmacies getting engaged in that process as well.
So is that, thank you for that. So is that to us, Toronto Public Health, or the Immunization Task Force at the city, is that to us to plan? I understand that the province is setting the hierarchy of the rollout and who gets what when, but the actual planning of a max vaccination, is that to us to do that and leverage these existing immunization frameworks that we have for the flu? Are we calling the shot and building that framework out right now?
So yes, in fact, and if you think about what Chief Pegg had mentioned in his remarks, we've got an immunization clinic that's a proof of concept one that's being launched today. The province's intent is that local jurisdictions and local public health units all around the province will establish and implement these kinds of immunization clinics, which is regularly done as part of, say, for example, flu campaigns. This is obviously going to be much bigger, right? And we're talking about a much larger proportion of the population, or certainly hoping that a larger proportion of the population will take advantage of this opportunity to be immunized. And as well, there are new technology supports that aren't traditionally used within the flu clinics that are being deployed for this particular vaccine. So you can see that while we're using the basic premise that we regularly use for large-scale community immunization clinics, there are some nuances and elements that are a little bit different about this COVID-19 vaccine, hence a proof of concept test that we're undertaking on behalf of the province starting today.
Okay, Mr. Chair, I can't see the time anywhere.
Yeah, I was just going to say you're just over 6 minutes. So what we'll do is we'll go to the next board member, and then we'll see if there's a desire for a second round.
Great. Thank you very much. Thank you, Doctor.
Thanks. So next I have Director Mulligan.
Thank you, Mr. Chair, and thank you to all of those who presented today. I have a few questions about the vaccination rollout. And I wanted to begin by just asking a little bit about the priority neighborhood response teams that you mentioned, Chief Pegg. Can you tell us a little bit more about what they are, who's on them, and what their mandate is?
Sure. So through the chair, I'll certainly start, and Dr. Davila can fill in as we go. So what we envision for priority neighborhood response teams are small but nimble, I guess, small teams of people that would be able to deploy directly into priority. They could be into priority neighborhoods. It could be down as granular into priority buildings, for example. We'll take direction with respect to where those teams get deployed. That will obviously come through the expertise provided by Toronto Public Health. And we're looking at and exploring a number of different operating models for that. We anticipate that will leverage the expertise and capabilities of some of our community paramedics to staff those teams, as well as nurses and a number of other exciting opportunities to make that happen. But those the prioritization of those responses will, of course, be informed largely by the excellent work that Anania shared with us and understanding what those priority neighborhoods are, of course, correlated with the lifetime data and the actual experience data that Toronto Public Health is providing. So to you, Dr. Davila.
Sure. So what I'll add to that is that we've had some experience working with partners and seeing the benefits of having testing directed in specific neighborhoods, where we know that testing has been not taken up well enough for a variety of reasons, not the least of which is access. So applying those lessons learned to immunization, we want to make sure that we're able to provide immunization and provide better access to vaccine to those neighborhoods that clearly warrant it, whether it's based on disease rates and or what we understand of vaccine uptake or lack thereof. And of course, it is premised and will rely quite heavily on the work that Anania and that entire task force is doing in order to leverage trusted relationships within the community to support better access to vaccine.
So just in follow-up then, is there a relationship with community agencies then and the priority neighborhood response teams? And further to that, I've been hearing that community-led testing staff and teams don't yet have access to vaccination, while their counterparts doing the same work, such as community paramedics, do. So I was wondering if you could also speak to that.
So sure, through the chair, a couple of things. I do believe that, you know, what the specific relationships will be with community agencies will develop as we figure out which communities actually require these response teams. And I think that will be quite fluid, but I think it'll be very important to actually engage with community teams. That's our lesson learned from testing. I would expect that those lessons should be deployed to good effect in respect of vaccine and vaccine deployment throughout the city. Around the vaccination of healthcare workers, we do know, you're quite right, you know, Director Mulligan, that these are high priority individuals, people who are either doing testing within the community and maybe doing immunizing as well in the community. Unfortunately, the challenge right now is one of vaccine supply. And as vaccine supply becomes more available, amongst those who are in that high priority group are healthcare workers who are at high risk groups, or who are at high risk either of exposure to COVID-19 or are dealing with patients and interacting with individuals who are high risk for severe outcomes. The very folks you described would be chief amongst those, but we are at this point in a supply issue challenge.
So the Metro Toronto Convention Centre Clinic, is it just for City of Toronto staff, or is it for others who do similar work?
So at this point, through the chair, it is a very small proof of concept pilot that provides for only 250 doses of vaccine a day. And it has been directed, you know, as part of that proof of concept to a very select group of individuals, many of whom are City of Toronto employees and others of whom are employed within the shelter system as frontline workers, particularly those working in harm reduction and with direct client interaction.
Okay. My next question is about the vaccine hesitancy work. So Anania, you might be able to support on this one. When I looked through the names on the subject matter expert task force, I didn't see any representatives of community agencies. And Dr. Davila, you mentioned the importance of working with those agencies in the past. And so I'm interested in knowing what their relationship is with that. And also, what's the difference between this subject matter expert panel on vaccine hesitancy and the work that's happening on the equity plan for immunization that already does involve community agencies?
So, and I'll just say, Anania, before you reply, we're just coming up on 6 minutes. So Anania, please reply with all the depth you have. Don't shorten it. But Kate or Director Mulligan will then come back for a second round as necessary. Anania, back to you.
Thanks, Councillor Cressy. So, to answer your question, this group is these are community folks, right? These are community folks that have the expertise in vaccine, and so that's why we have gone to them, because they understand not just the vaccine and have vaccine expertise, but they also are deeply rooted in community, and so we're leveraging both of those knowledge. With regards to community agency, this particular task force is being run through partnership with Taibu. So Taibu is our community agency who is leading this in partnership with Dr. Kwatu Kente, who is our special advisor on the equity plan. So just to let you know, I want to make sure that we have full understanding that as we roll out the communication and engagement and mobilization for immunization, we are speaking with and including and being informed by all these community agencies that are part of the equity plan as well as others. And so we will be developing right across the city, we will be developing four what we're calling working groups that will include community agencies, grassroots leaders, residents leaders, faith group elders and leaders, as well as members of the vaccine expert working task force. I hope that answers your question.
Thank you, Anania. Next up, I have Councillor Ainsley. Councillor, welcome to the board. Glad to have you. You're up.
Thank you. Thank you, Chair Cressy. Very happy to be here. Looking forward to working on the Board of Health. And I'd also like to thank Dr. Davila right from the start. I hosted a town hall meeting last week with our MPP and our MP. It was probably one of the highest attended or watched town hall meetings that we've done since the beginning of the pandemic. I want to thank Dr. Davila for taking all the time out of her busy schedule. I know it was very much appreciated by my community. Dr. Davila, I just wanted the reproductive number that's mentioned, the 1.05, that's an average number across neighborhoods across the city? So there would be higher numbered areas, neighborhoods than the 1.05, correct?
Well, it is an estimate overall for the entire city, and you may have noted on the chart that there are some, it's an estimate of what the actual reproductive number is, but there is in fact a range for which we believe the real number exists. And of course, the key point is that with that number being greater than 1, unfortunately, what that means is that the outbreak continues to grow.
Councillor
Mr.
Ainsley,
Chair,
did we lose you there? I put your time on hold, but I think Councillor Ainsley, you might have frozen. So what I'll do, Councillor Ainsley, if you can hear us, I'll ask you to maybe log off and log back in. I did pause your time there at just under 1.5 minutes. Councillor Ainsley, do we have you again?
Is he?
We can, yeah.
Yeah.
So you can start again. I'll restart your clock. I paused you at 1.5 minutes.
Okay.
Mr. Chair, are we frozen again?
Councillor Ainsley, it appears that we seem to be having a challenge with you. So what I'll do, you want to log off and log back in, and we'll come back to you starting at 1.5 minutes. And in the meantime, so Councillor Ainsley, maybe we'll have you try to rejoin. And in the meantime, I'm going to move over to Councillor Wong Tam, who I had next.
Thank you, Mr. Chair, and through you to Dr. Davila. What evidence do we have that in Toronto, workplace transmission is contributing to the spread of COVID-19?
So through the chair, Councillor, what we know is that as opportunities for people to interact become more contracted, right? There are fewer and fewer opportunities as we have more and more people hopefully staying home and working remotely. There are, of course, some workplaces where in-person work has to happen. So we do know that there are a number of outbreaks that happen within the context of workplace, and that right now gives us our best sense as to where transmission is occurring within workplaces when we pick up and detect outbreaks and investigate those outbreaks and understand what exactly gave rise to those circumstances.
Thank you. And do we know how many workers currently have access to paid sick leave today?
That may be a question that's better directed towards Tobias. I believe it's just under half, if I've got that correct. Tobias, is that, am I quite right on that?
To the chair, and thank you, Eileen. Yeah, so nationally, there are about 42% of workers in Canada have access to a certain number of paid sick days. That number for lower paid workers or workers who work in precarious arrangements is significantly lower, anywhere from 10 to 15 or 20%.
Wow. So anywhere from 80 to 90% of lower income workers do not have access to paid sick leave, is what you're saying.
That's correct.
And so therefore the majority across Canada, I think the percentage would be 58%, do not have access to paid sick leave. Is that correct?
So nationally, it would be 42% of workers across the country have some access to a certain number of paid sick days. And then as you look at different segments of the workforce, particularly for lower paid workers or those in less formal work arrangements, that number gets smaller and smaller.
So then without paid sick leave in Ontario, I'm just going to focus on our province for a moment. Without paid sick leave in Ontario and in a robust Ontario plan, will we be able to effectively and successfully stop workplace transmission?
Dr. Davila can speak to that, but certainly, as has been mentioned in the report and others have said, having paid sick leave is a critical tool to slowing transmission.
So through the chair, I would echo that. It is clearly not the only support that would be required and beneficial in terms of reducing transmission within workplaces, but it's one important tool that would contribute, certainly.
So last year, the federal government introduced the Canada Recovery Sickness Benefit. That was supposed to be some type of national program for sick leave. We know that, or paid sick leave, but we know that we don't have one yet provincially. But the province and in particular the Premier has spoken on numerous occasions. He has said, there's a federal program and that the federal government is going to, and the federal government's program should be sufficient, and therefore has stayed silent and done very little on announcing and creating a provincial program. Why is it that we cannot rely exclusively on the federal program for paid sick leave?
So through the chair, there are a number of concerns. While the federal program, the Canada Recovery Sickness Benefit, is helpful, certainly, there are a number of shortcomings with that program. One relating to awareness. We may have a situation where a number of workers simply don't know about it. There are concerns related to the access to that program in terms of language barriers in applying for that program. The amount of time it takes to apply for it and to process payments is also of concern. There are a number of eligibility criteria which may further exclude a number of workers who need access to a sick leave benefit of some kind. So that's also an area of concern. In particular, as a worker, you must have lost at least 50% of your scheduled work week in order to qualify for the Canada Recovery Sickness Benefit. And you also need to have earned at least $5,000 in the previous year or previous 12 months. So we may have a group of workers who don't meet either of those critical eligibility criteria. There are also concerns, again, around the timeliness of benefit payment itself. It can take 10 to 12 days if the payment is by check. If you haven't filed your taxes in a previous year, the federal officials may ask for further documentation, which could further delay payment by up to a month. There are concerns about the adequacy of the amount of payment that you get through this benefit. As mentioned in the report, it really is just equivalent to minimum wage, really, and depending on which province you're in. And I think perhaps most fundamentally, there's a concern that because it is not an employer-provided benefit, many low-wage, precariously employed workers may be concerned that if they take advantage of this federal benefit, they still need to go back into their workplace after a week or 2 weeks and face that manager and not have 100% confidence in the medium-term job security or longer-term job security. Fundamentally, I think that's the critical difference between a nationally provided benefit and one which is provided through one's employer, where it's normalized, legally mandated, and is a regular part of the benefit structure in that workplace. And therefore, the workers have confidence in relying on the benefit and staying home when ill.
Tobias, oh, sorry, go ahead, Chair.
Just saying we're just over 6 minutes. Okay. So I was going to say we'll come back if there's a request for a second round.
Sure, thank you.
Thank you. Councillor Ainsley has reconnected his Wi-Fi and has joined us again. So, Councillor, I had paused you at a minute and a half. So, Councillor Ainsley, back to you.
Okay. Can you hear me, Councillor Cressy?
We can hear you.
Okay, thank you. Dr. Davila, I wanted to ask about the ICU slide deck. Is that a worst case scenario slide deck, or is that what's going to happen if we continue our current reproductive number?
So through the chair, it actually provides the projections on ICU capacity for a number of different scenarios. And the different scenarios that are depicted on that slide are, changing reproductive numbers for the City of Toronto. So currently we are at 1.05 in terms of a reproductive number. And so that, would put us a little bit above. You can see that there is a trajectory there for a reproductive number of 1, and you see 1 as well for 1.1. 1.05 would clearly be somewhere in between those two. But this is just to give a sense as to, how much more demand on ICU capacity might we expect, depending on what the reproductive number is, which is, again, a reflection of how much spread and interaction there is between people.
Okay, all right, thank you. Talked about long-term home. I know that long-term care homes are being paired, partnered with local hospitals. Is that the case of long-term care homes in?
Through the chair, yes. The long-term care homes have been organized with hospitals in what's called a hub and spoke model, such that they have direct access to expertise and support on infection prevention and control from the hospital sector.
Okay, and that hub model, is it overseen solely by the provincial government, or does Toronto Public Health have a role to play within that hub?
So we certainly liaise in collaboration and partnership with the hospitals and the long-term care homes, and this would apply to retirement homes as well. We provide outbreak management and support should a given home find itself in an outbreak situation. And we also provide some support on infection prevention and control. But that on-the-ground clinical support and clinical infection prevention and control support is provided through the hospitals. We're a partner to help coordinate some of those activities and to liaise with them as well.
Okay, all right. And then my last question, Dr. Davila, was just for the vaccine rollout. I understand the different phases. And is there, when it goes to the general public, I think the one slide deck said we have a target date of April 1st. Is there a priority listing? Like, do we look at teachers, people that might have like diabetes, for example, or is it just similar to the flu vaccine rollout where it's on a first come, first served basis?
So through the chair, the province has provided a very high-level summary of their prioritization framework. And in the first instance, they're looking at seniors within congregate settings, healthcare workers, Indigenous communities, particularly remote and northern communities. And they have also named in this first phase adults who are receiving chronic home care. Beyond that, they've talked again very loosely around essential workers and expanding to other populations, but the granularity has yet to be fully provided. It is my understanding, though, at some point when vaccine is opened out more broadly, that eventually we will get to a point where it's more akin to the flu immunization program, where it is more broadly available and it is just a question of signing up. But I do think it will take us some time to get there, particularly given current vaccine supply challenges. I do think the province is changing, and the word they use is pivoting, on the fly as supply becomes an issue, and hopefully as supply becomes less of an issue over time. I expect to see pivots from them on what's next in terms of prioritization.
Okay, all right. Thank you very much, Dr. Davila. Chair Cressy, those are my questions. Thank you.
Thank you.
Thank you, Councillor. I have Councillor Layton coming next. Just before I go to Councillor Layton, are there other members of the board who haven't asked questions who wish to? Okay, I see Director Peter Wong. Let me move to my next screen. Any other members of the board with questions? Okay, so we're going to go to Councillor Layton, followed by Director Peter Wong, and then I'll see if there's interest. I'll see if there's any interest in a second round. So Councillor Layton, over to you. Councillor Wong, I'm going to ask you to take the chair for a moment. So we have Councillor Layton, then Director Peter Wong. Councillor Layton, over to you.
Thank you very much, Mr. Chair. To our medical office. So I think we established from Councillor Bradford's line of questioning, it's the province that outlines the prioritization framework. It's the province who decides who gets the vaccine and in what order.
Through the chair, that is correct.
So phase one has been established. We're and well established and underway for some time. Phase two is coming. Do we have an idea of when we may actually be entering?
Sorry, Councillor, you're cutting out.
Sorry, I'm asking about the timeline as we head towards phase two of the vaccine rollout.
So through the chair, I believe that the original plan as articulated by the province. Sorry, can you hear me? Okay, sorry.
Yes.
You seem to be cutting out a bit here and there. I believe that phase two, and I'll ask one of my team to correct me if I'm wrong, was slated to start at the end of March. However, I think there are some shifts as a result of vaccine supply issues that literally just came to the attention of the province days ago. So I can't speak with any certainty around what the anticipated timelines will be, given that there is a lot of uncertainty around vaccine supply at this point. So it's day to day. We are, hearing from the province as they hear more about the supply issues. We anticipate that they will have to adjust their timelines. My understanding is that they believe by the end of March they'll be caught back up. But again, it's let's see what happens.
So has the province shared any details about who will qualify in that phase two?
So they have provided at a recent press conference, there was a high level framework that was provided and they talked about, other populations. There was some mention of essential workers, but again, no real details have been provided. Sorry, I'm getting an echo now. I'm not sure if you're having challenges hearing me. Sorry, Councillor.
It's fine. It's fine now. Don't.
Okay. We're still awaiting much by way of detail. There are broad strokes of categories that are provided, but the focus really has been on the phase one populations, which I articulated, those seniors in congregate living arrangements, healthcare workers, Indigenous communities, particularly those that are remote and northern, and adults receiving chronic home care. Even that population within phase one has not been fully articulated by the province. So they are still focusing very much on congregate living, or seniors in congregate living settings, and to a certain extent, they were focused on healthcare workers. That has now been pushed back a little bit because of the vaccine supply issues. And it is very much that they're focusing on long-term care homes and retirement homes, high-risk retirement homes and populations there now.
So has the city outlined which vulnerable communities that we think should be prioritized as part of phase two?
So there is work, that should be prioritized as part of
phase two.
Of phase two? Not yet, because we actually don't know entirely what is happening within the context of phase two. We certainly are doing some work. You can see that we've put together groups that are looking at questions of communities that have been disproportionately impacted by COVID-19, significantly impacted by COVID-19. And as vaccine rollout starts to occur, we will be, of course, also looking at areas where vaccine uptake may not be as high as we would like it to be, in a very similar fashion to what was done and what we've learned from testing.
Now, if I could just ask one more question. It was outlined in the Globe this morning around the rollout in other countries with the use of volunteers. Is that an approach that we would undertake, or we've considered and ruled it out? I have residents reaching out saying, "Why can't we sign up? We want to help. We want to help," and just want to make sure that that's something that's under consideration, given the level of community support that people want to bring.
So why don't I start off, and I'll see whether the chief has anything further to add. There is a staffing plan for certainly our immunization clinics, and that does not rely on volunteers at this point in time. I would say that it's my understanding that the province has reached out, and they have an initiative underway looking at, I believe, healthcare professionals who have recently retired. We are also deploying a number of different options. I think you heard the chief mention, relying on our paramedics colleagues. We're certainly relying on our Toronto Fire Service colleagues to support and help with our immunization clinics as well. But we do have a significant staffing plan, and there is a big recruitment endeavor that's being undertaken as part of our immunization clinic plan. I would further say, though, that if I can, I believe in the future, the plan is to deploy the existing immunization infrastructure, not similar from what was done in H1N1 back in 2009. We have a number of primary care providers and pharmacies that are engaged in immunization. They routinely do immunizations, and really getting scale and being able to take advantage of that infrastructure all over the city will be crucial in terms of deploying vaccine as far and as wide and as quickly as is possible.
Thank you very much.
Thank you, Councillor Layton. Next, I have Director Peter Wong. Peter, when you're ready.
Thank you, Mr. Chair. Thank you, Dr. Davila, and all the teams that are working so hard. And thank you for all the presentations, because this is an immense planning and strategy. The amount of effort that goes into this is immense that I think we don't actually appreciate. But my question really is around vaccine hesitancy and resistance. I work in Rexdale, and I work with vulnerable communities and racialized communities, and vaccine absolute resistance is very, very challenging. So, the question really is to Dr. Davila and to Nanaya around our grassroots strategy. How are we going to know that it's working? Do we have any outcome measures or indicators that will suggest to us that our strategy is working? We don't really want to be trying to continue with a strategy that may not be effective. What kind of outcome measures do we have to reassure us that things are going along the right path? Thank you.
Anania, do you want to start with a little bit on the grassroots work that you're doing, and then I can chime in?
I think through the chair, thanks, Dr. Davila. I think that's an excellent question, Dr. Wong, which is one that we are working through. We're collecting from the agencies weekly reports, and some of what we're outside of course, how many people are getting tested and how people are responding. We're also doing, we want to see what the impact is. So we are doing monthly surveys with sample residents, because we want to know how the work that we're doing is actually shifting maybe how they're thinking or how they're responding. But we're also, one of the things that we're working on, we're working with TPH on this, is to identify a benchmark. And we're getting close, we're almost there. And so we'll use that benchmark to then determine what successes we've been able to meet. So I will say that is in progress. That's top of mind for us. Because if we do all this and we're not making the change, then but it requires data collection, and it requires that we hear from residents themselves beyond just the numbers, but also about how they're shifting and how they're responding to the work that we're doing, the rapid in particular.
Thank you, Dana.
So I think that, sorry, the only other thing I would add, if I may, is that obviously the proof is in the pudding. We're going to want to see, so what is the vaccine uptake like? And, you know, just in these very early days, even though supply is a challenge, what we're noticing now is that within certain populations, so for example, there were some long-term care home staff that raised some concerns around, you know, taking up vaccine and having COVID-19 vaccine. As more and more people are taking COVID-19 vaccine within the long-term care home setting, we are finding that, you know, recognizing that people, one, are actually taking vaccine, and two, are, you know, not reporting significant adverse events, that this is raising some confidence, at least in small ways, in those small, you know, sectors and in those locations. So it will be measured bit by bit, and it'll be interesting to see, you know, how we, you know, use, you know, our experience to help inform the next steps. I think that will be very critical as we seek to increase vaccine uptake as it becomes available.
Thank you both, and thank you for the great work that the whole team is doing.
Thank you, Director. Let me just see members of the board who have not asked questions. Does anybody else wish to ask any questions of staff? Okay, I will put myself on the list. Two quick questions to our doctor. The first is, Dr. Davila, you've spoken at length about the need for enhanced supports for those disproportionately affected, including those working in essential frontline environments. Will lockdown measures without those enhanced supports alongside them work?
You know, through you, Mr. Chair, we need those enhanced supports in order to maximize any benefit from any other public health measure that's being deployed. People we have found in our experience are continuing to show up at work despite the fact that they're sick or symptomatic, simply because they cannot stay home. They cannot afford to not be at work, and it's a difficult choice, and it's actually an impossible situation. So we need those supports in order to help control the spread of COVID-19 as best as possible across all sectors.
And thank you for that. I guess a follow-up in very simple terms for me then is, no matter how strict a lockdown may come, without providing enhanced supports like sick leave, some will continue to acquire the virus and spread it. Is that right?
So through you, Mr. Chair, that's been exactly the experience we've seen on the ground.
Thank you. And then my second question, you just spoke quite clearly in response to Director Peter Wong's questions around vaccine uptake and what we're starting to see in referencing there some frontline workers in particular. My question is, as part of the vaccine program, is the collection of disaggregated data for those who get the vaccine part of the process? So just as we collect data for those who are being, you know, as part of our contact tracing, are we, either as Toronto Public Health or the province, collecting disaggregated data based on vaccines? In other words, do we know whether certain people of different incomes, different races, different jobs are less likely or are not getting the vaccine at the levels we want to see?
So through you, Mr. Chair, the system, the information system, and the method by which data are being collected on those immunized is a provincial platform. I have not had a great opportunity to really look at it, but my understanding is that those data are not yet there. I will ask any of my team to correct me if I'm wrong, but certainly we are engaging in active conversation with the province around how these are important elements of data that need to be collected so that we can understand what's happening in our community around vaccine uptake in as fulsome a way as possible.
Can I just check if just to seek further clarity on that, Dr. Davila, if there are other members of the Toronto Public Health team who if we specifically know what level of disaggregated data is collected or not under the current provincial vaccine information system.
So looking around the virtual room, asking to see if we have any of my colleagues who are more familiar, and it is difficult to look around the virtual room, I will say
Yes,
that.
Dr. Finkelstein or Dr. anybody? Any of the other doctors?
So I'm afraid, Mr. Chair, I'll have to follow up with you after the meeting. I do apologize for that.
Sorry, it's Sarah here. I was on mute. Sarah Collier. I'm not a doctor, but I could probably answer the question if that's okay.
Sarah, you don't have to be a doctor to answer the question.
That's right.
Collier, Sarah, yes.
Thank you, Sarah.
Dr. Davila is correct. We are working with the provincial team to figure out what disaggregated data we will be collecting. And so we're putting forward our request of what we would like to see. It's very similar to what we've been collecting in terms of race and income in our case data, but we haven't come to a conclusion of what we'll be collecting yet.
Okay.
And sorry, Mr. Chair, to be clear, that is a provincial system. What goes into the system and the fields for data collection is under their control.
So can I ask then just one follow-up question is, would it be in line with Toronto Public Health's current conversations were this board to request the province of Ontario to collect disaggregated data based on race, income, occupation, and housing status as part of the vaccine process?
So Sarah, I trust that that's the nature of the conversations we're having?
Yes, that's correct.
Okay. So Mr. Chair, in answer to your question, I believe it would be helpful.
Those are all my questions. And Sarah, you don't have to be a doctor to answer questions here. So thank you for that. Okay, so those are mine. I did mention we're coming up on noon, but I did mention to members of the board that I would caucus to see if there were anybody who did have a second round who wished to ask further questions. Let me just see. I see Director Mulligan. Are there any other members of the board who wish to ask additional questions? Okay.
Mr. Chair, Councillor Bradford.
Okay, so I'm going to go to Director Mulligan, followed by Councillor Bradford, batting cleanup, and then we're going to move it in for speakers. Director Mulligan, when you're ready.
Okay, thanks, Chair, for indulging in a second round. I'm just, looking at the data showing rising case numbers, particularly in long-term care, and looking at the data showing we're starting to stay home more, and recognizing there could be some lag in between on the data. Dr. Davila, are we doing enough with respect to public health measures? Is there more we need to do to lock down? So the province announced, an emergency declaration, but it did not look that different from existing public health measures with respect to closing businesses or limiting people's ability to move around. Are we doing enough with respect to those lockdown type measures?
So through the chair, Director Mulligan, I would say this: we are starting to see, as I showed you on that graph, some increase in stay-at-home time, which is a proxy measure for reduced mobility, which I think is a good sign. We have to observe. I think it does take some time. We do know that it takes some time, at least a few weeks after measures are implemented before you see the full impact. And certainly within respect of long-term care, I'm happy to say that we have completed the first round of first doses to all our long-term care homes, in the city. So we are pleased to have that at least as some form of protection for those who we know are most vulnerable to the most severe outcomes. So I think every measure we take is a step in the right direction. I'm hopeful that what we've done will continue to show that that the reduced mobility will manifest itself in reduced activity. And I think as we have throughout the entire course of the pandemic, we'll continue to work with our provincial partners to make sure that they're aware of what we're seeing on the ground, such that they can inform their decisions appropriately.
Thanks. I have no further questions.
Thank you, Director. Forgive the sports metaphor here, but batting cleanup, Councillor Bradford.
Thanks for your indulgence, Mr. Chair. Just to kind of go back to some of the questions I was asking earlier about the immunization rollout. On page 4 of the report that we have here, it says that we are drafting a broader city vaccination plan, and that working to make sure that the mass vaccination clinics are ready to roll out with the arrival of additional vaccine supply for phase 2 and phase 3. Can you just reiterate when we're expecting to have enough vaccines for phase 2 and phase 3 in light of the Pfizer announcements and that lag?
So through the chair, my current understanding is that the vaccine supply gets to a better stage for, larger immunization clinics and more broad-based immunization undertakings by April. That's my current understanding, just given the vaccine supply situation. Right. As you know, Councillor, it changes quickly. We just heard a few days ago around this new supply challenge came up just a few days ago. So we're hopeful, based on provincial information, that by April, we should have bigger supply.
So appreciate that. The slides made note that we're planning to be prepared in advance of like that April 1st sort of be ready date that the province has now given us. Could you speak, or maybe this is Chief Peg, not sure, could you speak to the drafting of the city plan that the report was speaking to, the city vaccination plan, how that's progressing, where we are in respect to having that ready to go? Is it ready to go, or are we waiting for approval from the province in order to implement that? And, when these vaccines get here, are we going to be ready?
And Dr. Chief Peg has had to take an urgent meeting that just came up, so I'm going to ask you, Dr. Davila, to answer on his behalf, if you don't mind.
Of course. So I'll do my best to fill the chief's very big shoes, and not an easy task. But let me start off with this. There's been a great deal of planning, as you heard from Chief Peg, under the Immunization Task Force. The plan is to have a number of sites where immunization clinics will be offered, and there's a range of them throughout the city, throughout the entire geography of the city. The plan also considers these response teams that can go into specific neighborhoods and some mobile clinics as well, in order to really penetrate every aspect of the city over and above using the existing immunization infrastructure, as I spoke of in an earlier answer. We know that primary care providers are the major provider of immunizations at pharmacies. So it's this overall overarching immunization plan that looks at our resources in the city first and foremost, and expects that there will be likely the use of the immunization infrastructure through primary care providers and through pharmacies as well. That is all fully worked up. And the chief and his team have worked very hard, such that I believe that they have indicated they would be ready long before, the end of the first quarter.
Sure.
Again, the dates will depend more on the supply of vaccine than they do on our readiness of the city. They're prepared to accelerate.
Okay, I'm just watching my clock and the time here. Is that plan going to come here to Board of Health? Are we going to see that or have an update on that? Some more specificity?
So given that our next meeting is not until March, I will work together perhaps with the chair to make sure that you have some communications, because I do expect that these things will continue to develop over the course of the next several weeks. You can rest assured that the Immunization Task Force Command Group is constantly overseeing this, and we will make sure that you as members of the Board of Health are kept informed and up to speed.
Okay, and then my last question, with respect to it's great that we have the site at Metro Convention Center up and running today. Congratulations, and that'll be a model going forward. How have we determined the general geographic approach to the 640 square kilometers that we have here in Toronto, and how we're going to do that across the city? How is Toronto Public Health identifying those sites? Have they been identified?
So through the chair, Councillor, yes, the major sites have been identified. What has yet to be identified are going to be where do we need to do very specific focused undertakings to respond to specific areas of need. Mobile clinics, that kind of thing, that will be determined on an as needed basis, but we have fully covered the geography of the city. And I would say that in concert with our partners throughout the city who have facilities all over the city, we have the flexibility and the capacity to provide clinics on an as needed basis when we see need, and if we feel that our proposed plan isn't sufficiently meeting the needs of various populations, we'll adjust.
Well, thanks, Dr. Davila. Thanks, Mr. Chair. Appreciate it.
Thank you.
Thank you, Councillor. So we're going to move this into committee for speakers. And so I'm just going to draw a speakers list here. If people could, start by way of a show of hands, indicate if they wish to speak on this item. I have Councillor Wong Tam, looking others who wish to speak. Flipping pages here, forgive me if I don't see you. Okay. Councillor Wong Tam, we'll begin with you, and then I'll check again for other speakers.
Thank you very much, Mr. Chair, and thank you again to all the incredible hardworking staff at Toronto Public Health, as well as everyone else who's been mobilized to really work together to combat the virus. This is a very good report and one that actually helps us once again benchmark where we are with the fight against the coronavirus. And I want to thank all of you for your contributions to the outcome of this information. I want to speak in particular around the paid sick leave benefits, and I think that as we have seen and clearly identified from the data, is that many people are able to stay home, but there's also a great number of people who cannot. And Tobias's remarks was quite illuminating with respect to the shortcomings of the federal program. I think he highlighted about 11 to 12 obstacles that are technical in nature, but also are very real for earners and workers of that are deemed essential on why they don't have access to the paid benefits, and how the federal program does fall short. And we know that this board has repeatedly now asked on several occasions that the province of Ontario provide some type of benefit for employees so that they can have access to paid sick leave. And during this pandemic, it has now become increasingly evident that the absence of adequate paid sick leave provisions is actually furthering the transmission in the workplace. And we've heard now from both Dr. Davila as well as Tobias, as well as Chief Peg, is that we're not going to be able to get in front of the pandemic and to slow the community spread unless we can actually ask people to stay home safely. And we're not going to beat them. We're not going to be able to beat this virus unless a very critical tool gap is filled. And that's the paid sick leave piece. Which is why it's so critically important that when the province says they're doing everything they can, that every tool is on the table, that we have to continue to press upon this point, because there is not every tool that's been placed on the table. And this is one very, very obvious tool that they have left behind. And the pandemic story now is starting to circulate around what is an essential worker and whose lives are important. And it's important for us, I think, also to recognize that those frontline essential workers really have no choice until this paid sick leave program is actually going to be constituted by the provincial government of Ontario in this case. We see that 60% of Toronto's workplace outbreaks have been in frontline food processing, manufacturing, and warehouse studies. We've also heard from city staff is that many of those individuals do not have access to paid sick leave, as well as 58% of working Canadians across the country don't have access to paid sick leave. 80 to 90% of individuals who are low-income workers do not have access to paid sick leave. We are not going to be able to beat this pandemic. We are not going to be able to get in front of the curve until we address this very critical and very important policy gap. And we cannot ignore the fact that low-income earners, essential workers, frontline workers, they are overwhelmingly represented by racialized communities. Poor people of color is what is fueling our essential survival right now for those of us who are fortunate enough to be able to stay home safely. Other people are on the front lines doing that essential work. And it is their lives that we continue to put at risk, and their families and their communities' lives, while we don't have a paid sick leave program. Whether it's 10 days or 14 days, we need to have this in place as soon as possible. If the City of Toronto could do it, I would even offer to City Council that we do it. Let's just get it done. But we don't have the mechanism to do it, nor is it within our purview, nor do we have the finances to do it. So we need to rely on the provincial government to take action, and sadly, they have not. So if there is going to be any wearing of responsibility on whether or not this pandemic gets worse and we move into a third wave of infections, it is going to hang. This responsibility is going to hang very squarely, very neatly around the neck of the Premier and this government. They have to take action. Staying silent, doing nothing, deferring to the feds is not a response. It's not an accountable solution, and we expect so much more from them. And hopefully, City Council will again come forward with more forceful recommendations, as contained in this report, asking once again succinctly that they need to get this done. Thank you very much, Mr. Chair.
Thank you very much, Councillor Wong Tam. Let me do a final call for any other speakers on this item. Okay, seeing none, I'm going to put myself on the list as the final speaker. Let me begin first by moving the staff recommendations in front of us, as well as moving, and I'll ask our staff in the Clerk's Department to post a rather comprehensive and fulsome series of amendments that members of this board and members of Toronto Public Health staff have worked so hard on, and I will briefly summarize them before giving some broader comments. First, it is for City Council and the board to urge the province of Ontario to take immediate action to address the rising rate of new COVID cases, hospitalizations, and patients in intensive care units by providing additional supports to essential frontline workers, including the paid sick leave recommendation we've discussed, as well as targeted support for temporary workers and enhanced proactive workplace inspections, to continue efforts to expand test, trace, and isolate systems, to provide additional financial relief to ensure that affected workers, businesses, and individuals are supported during this lockdown period. And as well, here are the additional recommendations from the Medical Officer of Health mentioned in her presentation, to continue to monitor the provincial circumstance and other evidence in order to adjust measures as necessary. As well, a call for the province to provide the operating funding that's necessary for our new supportive housing units that are opening now. As we turn our attention to vaccines, there are a couple specific recommendations here. First is, as part of the phase 2 process, which is when the province has indicated that high-risk vulnerable populations will receive vaccines, is for the province to provide a specific breakdown of the individuals and groups who will be prioritized in phase 2, a very detailed and specific breakdown of who those individuals and groups are and where they fall in the prioritization. As well, there is a request for Toronto Public Health staff in consultation with ITF to report back to us on the specific plans for each of those high priority groups that are identified, what Toronto's plans are, or the province's, to support them and ensure they're vaccinated, whether that's the homeless community, whether that is workers in essential frontline environments and other areas. Also on the vaccine, a request for, as part of the province's immunization program, to collect disaggregated data on the vaccine campaign based on race, income, occupation, neighborhood, and housing status, as we have pushed for as part of the COVID response, and for our staff at Toronto Public Health to explore how we might collect that data ourselves. And then finally, I would note is a request for the medical officer of health, as we've indicated before, that we have her back if she feels it's necessary to implement any additional measures or restrictions necessary. And sorry, there was one last one there, which is for our medical officer of health to ensure transparency and privacy, to adjust the workplace outbreak reporting criteria to ensure that transparency while protecting privacy, and to report back on those measures. So that is a broad package, and sorry for the length of time there, and thank you to all who have worked on that. I want to echo that which has been said by others in thanking Dr. Davila and her team, every single member of the 2,000 plus member team of Toronto Public Health, for the professionalism in which they're doing their work, but also the compassion that they're doing as they use every ounce of energy they have. They are digging into the deepest well of reserves that they possess to keep fighting through, and we commend them for it. The same to Chief Pegg and our Immunization Task Force team and the Emergency Operations Center, who have been indefatigable. And you heard here today from Anania Grant, and the leadership that Social Development and Finance Administration has brought to the fore in embedding equity in our response cannot go unnoticed. We are coming up, January the 25th was the first day we identified a case in Toronto. It's nearly a full year we have been in a full pandemic response. We've seen 77,000 cases as of today in our city, more than 2,000 deaths, and this is not abating. We have 35 current outbreaks in hospitals, 50 current outbreaks in long-term care. And while the end is in sight, because of the unprecedented science that has brought a vaccine forward, the end will not come before an absolutely brutal winter. It's gut-wrenching and heartbreaking to hear every single day the number of people who continue to die from this virus. And the case counts remain high, the reproduction number remains above 1, fatigue is set in, and folks, we have more transmissible variants in our province that could take hold. And so we have to prepare ourselves for the very real potential that our ICU units will be overwhelmed, that our hospital partners are having to implement triage scenarios that many medical professionals never thought they'd have to, and that we will continue to see deaths. I mean, that's the scenario in front of us. And so while we must prepare ourselves for that, I think more importantly, as a board and as a city, we must take every action, every potential action to mitigate this harm, to prevent the unnecessary loss of lives, to do more and do better as a city, as a province, and as a country to protect our residents and their health. And there was a time where we talked about the need for balance. There was a time we talked about the need to learn to live with COVID. But what we've learned is that the only way you beat this virus prior to mass herd immunity through a vaccine is by targeting 0 cases. You beat this virus by driving the case count down to near 0 and by providing the measures and supports to protect people who must continue to work and to support people who are affected by those lockdowns. It's the only way. Atlantic Canada, New Zealand, Australia have shown us. And so hard lockdowns to reduce contacts and limit transition, protections to support essential frontline workers, sick leave, sick leave, sick leave. If we've said it too much, we have to say it louder because we haven't got it yet. Enhanced measures for test, trace, and isolate systems, a fast vaccine rollout, and those supports to mitigate the harm on residents. Isolation is hard, it's brutal, and it can have negative health and economic effects. And so 1 year in, I will say that it pains me that we keep seeing governments trying to implement restrictions without providing the support to go alongside them. We keep seeing government say we're listening to the public health experts. Well, I have yet to hear a public health expert not demand paid sick leave now. So if you're a government, if you're this provincial government and you listen to the health experts, then I demand to see paid sick leave now. Otherwise, you're not listening. In fact, you're ignoring them. And so as we turn as a board to hope and vaccines, the largest campaign in this nation's history, we will collectively roll up our sleeves to get those needles and that vaccine, and we will roll up our sleeves to do the necessary work to get that vaccine out to the vulnerable populations in the quickest time forward. We must scale that up, but we got a couple tough months in front of us. So we will rise to it, we will fight through it, and we will demand more and better. And those are my comments. Thank you. That we have the staff recommendations and a package of amendments in front of us. Can I ask if there is a willingness on the part of the board to take all of those together? Okay. To our recording secretary, could I ask for a recorded vote on the motions, the staff recommendations, and the package as amended in front of us?
Directors, when I call your name, please unmute your mic, indicate your vote by stating in favor or opposed, and put your mic back on mute. Director Paul Ainsley.
In favor.
Director Ashna Bowery.
In favor.
Director Brad Bradford.
In favor.
Director Joe Cressy.
In favor.
Director Stephanie Donaldson.
In favor.
Director Angela Johnson. Director Angela Johnson. Director Mike Layton.
In favor.
Director Ida Lopretti.
In favor.
Director Kate Mulligan.
In favor.
Director Gord Perks.
In favor.
Director Peter Wong.
In favor.
Director Sue Wong.
In favor.
Director Kristen Wong-Tam.
In favor.
And Mr. Chair, that carries with 12 in favor and 1 member absent.
Thank you, members. That is unanimous. Okay, and then we have, clerks have advised me that we have to reopen item HL 25.6. This is the service agreement for Ontario Seniors Dental for the dental care program. Director Mulligan, I'm advised that we need you to state the nature of your interest, and then when you exit, we do need to take a recorded vote. It's not enough for you to be off the camera, I've been advised.
Thank you, Chair. The nature of my interest is that I'm employed by the Alliance for Healthier Communities, which is the association representing Rexdale Community Health Center, named as a funding recipient in this item.
Thank you for that, Director Mulligan. So, Director Mulligan, I'll ask you to turn your video off. And to our recording secretary, I understand you need to call a recorded vote. Is that correct?
That's correct, Mr. Chair.
Okay. Over to you then. Thank you. And Director Mulligan has left the meeting.
So directors, when I call your name, please unmute your mic, indicate your vote by stating in favor or opposed, and put your mic back on mute. Director Paul Ainsley.
In favor.
Director Ashna Bowery.
In favor.
Director Brad Bradford.
In favor.
Director Joe Cressy.
In favor.
Director Stephanie Donaldson.
In favor.
Director Angela Johnson. Director Angela Johnson. Director Mike Layton.
In favor.
Director Ida Lopretti.
In favor.
Director Kate Mulligan. Director Gord Perk.
In favor.
Director Peter Wong.
In favor.
Director Sue Wong.
In favor.
Director Kristen Wong Tam.
In favor.
And Mr. Chair, that carries with 11 members in favor and 2 absent.
Thank you very much. That concludes all the items on our agenda today. So with my deepest gratitude to members of the board, and welcome once again to our new members of the board and to our Deputy MOH, Dr. Lamptey. And so to everybody, stay safe, keep your distance, and let's keep going. Thank you all.
Thanks, everybody. Stay safe and well.
Thank you.